Welcome to This Week in Emergency Medicine. This week we're covering 5 notable papers spanning emergency department, ultrasound applications, and clinical practice variations. Let's dive in. We begin with a focus on expanding clinical ultrasound applications in the emergency department, where new evidence highlights both diagnostic versatility and substantial system-wide benefits. In the American Journal of Emergency Medicine, Shokohi and colleagues present a comprehensive framework for utilizing point-of-care ultrasound in patients with suspected shoulder dislocations. While the traditional posterior glenohumeral view is highly reliable, it is often difficult to obtain in patients who are immobilized, in severe pain, or undergoing procedural sedation. To address this, the authors outline alternative anatomical windows, including anterior, lateral, axillary, and dynamic approaches, and introduce several novel diagnostic signs, such as the posterior gutter and coracoid contact signs, to help clinicians confirm dislocations and verify successful reductions in real time. Moving from joints to vascular access, another study in the American Journal of Emergency Medicine by Barton and colleagues evaluates the macroeconomic and safety impacts of ultrasound-guided peripheral intravenous line placement for patients with difficult intravenous access. Utilizing a national Monte Carlo simulation model based on United States data, the researchers found that integrating ultrasound-guided access into standard protocols leads to an estimated annual opportunity cost savings of over $1 billion, driven largely by saved staff time and the avoidance of central venous catheters. More importantly, the model estimated that this practice avoids nearly 4 million central line placements annually, preventing over 200,000 total complications, including major events like pneumothorax and deep vein thrombosis. Taken together, these studies emphasize that expanding our ultrasound proficiency, whether for joint evaluation or vascular access, directly improves procedural safety and operational efficiency. Next, we turn to critical clinical decisions and practice variations in acute emergency care, starting with blood pressure management in neurological emergencies. A study by Shi and colleagues investigates the outcomes of early intensive blood pressure reduction in patients presenting with acute intracerebral hemorrhage. While controlling hypertension is essential to limit hematoma expansion, the authors demonstrate that overshooting blood pressure goals and causing excessive, rapid drops is associated with significantly worse functional outcomes for patients. This highlights the need for careful titration of continuous infusions to avoid precipitous pressure drops. Beyond acute resuscitation, clinical outcomes are also influenced by broader systemic factors, including who is delivering the care. 2 companion papers. Lai and colleagues examine how physician sex correlates with clinical practice patterns and patient outcomes within the emergency department. These studies highlight that subtle differences in clinical decision-making, resource utilization, and communication styles can exist among clinicians, reinforcing the importance of understanding practice variations as we work toward clinical standardization and equitable patient care across our departments. If you only have time for one paper this week, make it the study by Shi and colleagues in the Annals of Emergency Medicine on the risks of overshooting blood pressure goals in acute intracerebral hemorrhage. This paper serves as a critical clinical reminder that when we treat acute hypertensive emergencies, overcorrecting and dropping the blood pressure too far can be just as detrimental to neurological recovery as undertreating, urging us to monitor our infusion rates with extreme precision. Here are the key takeaways from This Week in Emergency Medicine. First, when managing acute intracerebral hemorrhage, avoid overshooting blood pressure targets, as overly aggressive reductions are linked to worse functional outcomes. Second, expand your ultrasound toolkit for shoulder dislocations by utilizing alternative anterior, lateral, or dynamic windows when standard posterior positioning is limited by pain or spinal precautions. Third, prioritize ultrasound-guided peripheral intravenous access in patients with difficult access to reduce reliance on central venous catheters, which can prevent thousands of procedural complications and save substantial institutional costs. Finally, pay attention to practice pattern variations within your department, as highlighted by recent data examining how physician practice styles influence resource delivery and patient outcomes. That's your roundup for This Week in Emergency Medicine. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.